So today we're actually going to talk things beyond your gram patch in peptic ulcer disease. What do I mean? Well, you have to understand when dealing with perforated peptic ulcers, most people are only comfortable doing a gram patch, which is an ornamental patch. If it's modified, you close the perforation and then put that patch on top. But the important thing is what to do when that is likely to fail. And so today we're actually going to talk about options, which is going to include your antrectomy, management of complications, and then the different types of reconstructions, which are three. You could have a B1, B2, and a Roux-en-Y, and we'll discuss all the tips and tricks that you need to know when managing something that's difficult, like a large perforated ulcer. Let's check it out. So to start, let's actually draw the anatomy. So if you have a perforated duodenal ulcer, to begin with, we already know that this is a hypersecretory acid problem. And whether you have H. pylori or not, that's another thing. And most important thing is how to manage it. So for perforations less than 2 cm, you could do a modified gram patch. What is a modified gram patch? You actually place suture to close the defect. After the defect is closed, you tie it down, then you can put a tongue of omentum to secure it. So it closes the primary defect and then secures the tongue of omentum. One important thing to remember is if you have a perforation in the stomach, make sure you biopsy it because you have to suspect, could it be cancer? And your primary goal is to alleviate these symptoms, but to have a definitive diagnosis, we can always come back in the future, but missing that one is very deadly.
Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button and let's keep on going.
Okay? But what if it is greater than 2 cm? Well, you have to classify important things and then prioritize your goal. The priority of your goal is, number one, control sepsis. Okay, so you have source control. That is your goal. Number two, when you have a perforation, you want to think about how are they going to eat. So that's going to be enteral access. And enteral access may mean them eating normally, them eating through a tube feeds, them eating to a different type of anatomy. Number three, are we treating the ulcer? So definitive ulcer management. So when somebody is septic, am I going to be trying to get all of this all together? Do I do it that same day? Probably not. When do I do it? What are my options and what are the repercussions of each? So that's what we're going to talk about. So anything that's larger than 2 cm, one consideration that you can do is do a damage control. And in that aspect, you can perform an antrectomy, and an antrectomy is defined so from your body, dividing your body to your antrum, and you will have your incisura angularis, which is here. And so when you're dividing that, this is going to be your antrum. We're going to divide it like that. Pardon my drawing there. But when we divide the antrum, you can actually resect the perforation if it's in D1. So you'll end up with a stump. Question: is the patient stable or unstable? If the patient is unstable or they're septic, then you can do this in two forms or two stages. You can do that one, ensure that there is no NG tube when you're dividing it. Number two is going back to the patient, leaving a temporary abdominal closure and then fighting again another day once they're stable so that you can focus on your reconstruction, because this provides source control and this also is a definitive ulcer management, and this is one option. So when you do that, you can put your Abthera dressing, resuscitate them in the ICU while they're intubated. Once they're off pressors in 24 to 48 hours, you take them back. Personally, I would re-resect my staple line and ensure there's a good washout. Now the question is, what are the types of reconstruction? Because you have to address your enteral access. So you could have a B1, which is a gastroduodenostomy. And that would be connecting your stomach to your duodenum. A B2 is a gastrojejunostomy. When do I do a B1 versus a B2? Personally, I do a B2 more frequently, and the question is, am I doing a B2 or a Roux-en-Y? And we'll get to the Roux-en-Y in a few. So when you have too much tension between the duodenum and the stomach, you don't want to do that anastomosis because it's likely to have complications and fail. When you do a B2, you can do it either Antecolic, meaning in front of the colon, you can bring out a loop of jejunum and then suture it to the body of the stomach. You can suture it into the posterior wall, which I prefer. Some people suture in the anterior wall. I wouldn't do it on the greater curve because all your vessels are there. You don't want to devascularize your stomach as you do your anastomosis. Or you can do it retrocolic. When do you do things retrocolic? If there is going to be a shortage of reach. It's going to be a shorter passage when you incise the the mesentery next to the left of your middle colic artery. So there could be a space there where you can put out a loop of jejunum. I personally bring around 30 to 40 cm from the ligament of Treitz and then bring it up and then do a side-to-side stapled anastomosis. When do we do a Roux-en-Y? Okay, so now you have here, and you can have a biliopancreatic limb that goes here, and then you can do a common channel and a Roux limb here. I prefer a Roux-en-Y when there is going to be reach issues. Let's say you have a higher ulcer and a larger resection. Reconstructing it with a Roux-en-Y is going to be a consideration to allow less tension of a reach. Other things that you can differentiate is, this is prone to bile reflux. This is prone to bile reflux. This actually, if properly constructed, is the solution for bile reflux, because your biliopancreatic limb goes down here to the common channel and then the bile goes down there. Here, if your bile is coming from here, you may end up having bile reflux there, going back up. Here, the same thing because you just lost your pylorus. Why is bile reflux pertinent? Well, besides the fact that the patients do complain, it also causes gastritis, and there is actually literature in which chronic bile reflux after a gastrojejunostomy is one risk factor for malignancy, which actually becomes significant at around 15 years. And that's a very important thing. What are the pros and cons with Roux-en-Y? Why not just put everybody with a Roux-en-Y? Well, if you have no bile here and you still have acid production, you can actually develop a marginal ulcer. So if you leave a large piece of stomach or part of the antrum in there, this is at high risk of marginal ulcer formation, which is going to be at the jejunal limb past the anastomosis, and that can either bleed or perforate. Other options include doing a truncal vagotomy. If you are unstable, that's not a good idea. The other thing that you have to consider is if you're doing a truncal vagotomy, they actually have other effects besides acid suppression. So your option is you can keep them on a PPI or do a truncal vagotomy, but knowing that when you do a truncal vagotomy, they could have a gastric emptying issue since you still have a large portion of your stomach. Also, it may affect the bowel motility as well. And so these are things that are to be considered. Other risk factors include internal hernia formation. Make sure you close your defects on a Roux-en-Y, and vitamin deficiencies. So it's not a straightforward answer when you're doing a reconstruction because of the change in anatomy. However, understanding which and what to use after a damage control procedure on something that's complex beyond the typical gram patch is very important. If you guys found this useful or helpful, please click the like and subscribe. And why don't you guys, how do you guys manage giant perforated peptic ulcer? What are the other techniques that you guys have done or are considering? And do you guys want me to clarify anything on subsequent videos? And you guys can check our other videos talking about peptic ulcer disease. And I'll see you guys next time.